Can you see the PowerPoint now?
Yeah, sir, it's visible.
You are seeing the PowerPoint now?
Yeah, yeah.
Okay. So the topic is basically management of diabetes, and there are OHs and there are insulin. So here we will talk about insulin and some of the aspects which are important for doctors as well as patients that I will cover in my diabetes and insulin education section separately. So here we will be dealing mainly the deep theoretical aspects of insulin. So we will not be covering diet, exercise, insulin education, management of diabetes complication in this lecture. Uh, so if you see this car, if someone asks how many tires are there in this car or in this Ashok stump, how many lines are there? Uh, like you will normally say, sir, there are four lines and there are four tires. Though we can see only one tire and three lines, but still we know uh, there is something which we cannot see but we can predict. In diabetes also, the treatment, insulin, medicines, they form basically just one aspect. Other three aspects are diet, exercise, and monitoring. So if you want to control diabetes of anybody, these four things should be fully balanced. Then only we can control the diabetes. So though this in this lecture we'll be talking mainly about insulin, but we should be very clear about uh, that there are three other aspects which need to be fully tackled to control the diabetes. So if we see the thought of normal person, what we think about family, we think about friends, food, school, money, hobbies, you know. Uh, we think so many things. Like all of you think about like what movie to go, but a type 1 diabetic patient who is on insulin, he'll be thinking about carb counting, like how my testing will be done, how I will get insulin, whether my sugars will be low, how I will tolerate pain, how I will inject insulin in public place. So his entire life is occupied by these thoughts, and that is the most important challenge for anybody who has a chronic illness like diabetes. And type 1 diabetes is one of the most challenging because you have to live with this disease throughout your life with 3 to 4 injection per day. And in top of that, there are monitoring of 6 to 7 times, many times, of glucose. So those who are familiar with the history, that life, liberty, and pursuit of happiness. This is a famous line, which is also known as American Dream. And Americans fought their freedom from Britain because they wanted these things. So if you ask any American what they value most, that is life, liberty, and pursuit of happiness. And these are the even value of French Revolution. So what is this life, liberty, and pursuit of happiness? Like no matter what disease we have, we want that our life should be not only long, it should be of good quality. We should be like we should have more freedom. Like the treatment and other aspects should not be like restricting our life. And what we want to do in life, we should able to do no matter what disease we have. So in diabetes also, not only we target good quality of life and longer life, we also try to give patient more liberty and freedom, and that is how that insulin pumps and newer things are coming to treat that artificial pancreas and second generation, generation insulin pumps, which are gradually moving towards more and more free form of uh, diabetes treatment, especially for insulin dependent patients. And they should also have like a freedom for that pursuit of happiness. Like somebody is swimmer, somebody is athlete, somebody is performing some social task or political task or academic task. You should all do what you like, and for that the treatment part should be very normally fit into your life. And that is how we are going for new drugs. And so whenever you treat diabetes, these goals should be very clear in our mind. So now coming to the what are the targets we are targeting in diabetes. So traditionally we always say that HbA1c should be less than 7. Preprandial or fasting glucose should be like less than 130, so range is like 80 to 130, and the postprandial should be less than 180. So these are our traditional targets. But now gradually, when we discuss that life, liberty, and pursuit of happiness, like we have to be liberal with certain populations, like those who have frequent hypoglycemias. We should be less stringent. Similarly, those who have longer duration of diabetes, those who have less life expectancy. For example, somebody 85 year, 90 year, there's no point of pushing him below 7. For him, even 8, 8.5 is a good HbA1c, because why we are treating diabetes? We are treating diabetes to prevent long-term complication, but somebody who has already have some established complications, and somebody who's already reached towards the end of normal human cycles, for example 90 years and 100 years, or somebody who has managing hypoglycemia is very challenging. Those who are poor by social economic supports, those who are less motivated, we should not be go by just a very strict number that your HbA1c should be less than 7 and fasting should be less. So we can be little liberal with that. So what is the liberal? For example, for 85-year-old, my fasting target will be 150, less than 150 will be very good target. Similarly, postprandial up to 250 is okay. So somebody who has 3-4 disease, kidney disease, heart disease, and a poor social support system, there is hypoglycemic unawareness. So for all these population groups, our goal will be around 8.5 HbA1c, and fasting and BP will be less strict compared to the traditional things. So when we decide treatment, we should always not only theoretical aspects like which insulin to write. We know like some insulins are very costly and some insulin are very cheap. So we should think about economic factors, social factors, like how he will keep those insulins, how he will purchase, how that regular, like whether they are covered in insurance or not, because it's a chronic disease. So these aspects I will cover in detail when I talk about insulin and diabetes education, because this is that will be equally important for patients also, like how to purchase insulin, how to inject insulin, and how to take care of various aspects of insulin injection related things. So now, if somebody asks, if I am a diabetic, and if somebody asks like insulin is boon or bane, most of the people will think it is bane, because somehow they are like totally full day they are engaged with this insulin, because body normally secretes insulin on its own for every few minutes. And on the other hand, we have to inject from outside. That is very painful. We have to monitor. But if you see the entire history, like before insulin came, you can see this girl and this boy, they had type 1 diabetes, and they lost almost all fat of their body, and they are, gradually going towards, mortality. So initially, before 1920s, people of type 1 diabetes had very limited life expectancy and very poor quality of life. With the coming of insulin, they gained weight, they lived a normal life, and they did. Now we know that most of the type 1 diabetes, they can reach 80, 85 if they control their sugar very well. So they are reaching almost normal life. So this is the timeline of insulin. Like initially we had insulin from animal sources, and in 1980s that human insulin came, which is not from bovine or porcine porcine sources. So when a patient or somebody asks like about insulin, we should make them very clear that in 1980s the human insulin was very costly. Even the richest in our society will not be able to afford that. And now even one of the very lower middle or even poor person can afford insulin by either support from government or their own also. So gradually insulins are becoming cheaper and cheaper, and especially if patient is on 3 or 4 drugs. That time, if you compare with the most low cost insulin, they'll be almost lower than those medicines, because now sometimes like if you take 3-4 diabetic medicine, insulin will be cheaper than them. So coming to the types of insulin, See, body has only one type of insulin, that is regular insulin. That is the normal insulin, what we say. And uh, when we that's insulin when we inject in subcutaneous form, it releases over a period of 6 to 8 hours duration. Onset of action is uh, 30 minutes. So people have realized that like if you have injected insulin now and you have to eat after half an hour, uh, so much time we don't have in modern life. If you see, people are busy and they don't have 1 hour, 1 to 2 hours for lunch and all those things. So they have gone for like rapid acting insulins, those who are most faster in release. So they release within 10 to 15 minutes. They are SPART, less proglylysins, and their action duration is basically shorter. And uh, similarly, we have NPH insulin with the help of protamine. We have made the release pattern of insulin little longer, that is 12 to 16 hours. And then there is glargine, which acts for 24 hours. Then there is degludec, which has like duration of almost 48 hours. And there is detimir, which has 20 to 24 hours action. So how these insulins are having different length of duration of actions, that we need to understand, so that we will be very good with this. First of all, we should know that body needs two type of insulins when we are giving outside. So in body, in normal body, what it does, it releases insulin every minute. If you eat from outside, it will release more. Otherwise, it will be releasing with a constant rate. But when you give from outside, you will have two type of requirement. One is like when you are when you start the car and you are not driving it. Even then, we will need petrol just because we have started the car. So that is requirement is called basal requirement. Like our cells are functioning, our body is functioning, so for maintaining all those basal things like basal metabolic rate. Similarly, there is basal insulin requirement, and that is almost 40 to 60%. So roughly 50% of total insulin requirement is basically basal form of requirement. Then there's another form of requirement, like when you drive the car. So whenever we eat something, that time we require more insulin to cover those hyperglycemia thing. So in diabetes, like we have high glucose and we have low energy. Normally, in a normal person, what happens? We have more glucose means more energy, but in diabetes, more glucose means less energy, because glucose is in the blood, not in the cells. From blood to cell, that you need insulin. So body has less insulin, so glucose in the blood cannot reach intracellular level, and it cannot generate enough ATPs. So energy will be low. So just we'll go towards like those longer acting insulins. Basically, they cover that basal requirement. So there are NPH that requires two times injection. Then there's glargine and degludec and detimir. They can be given daily injection also. So this is the molecular structure. You must have read this in your biochemistry. That it has two chain, A chain and B chain, and it has 21 and 30 amino acids in A and B. And if you see, these are the amino acids which are different in all of them. You have to remember like some of these insulin. Like if you see lispro insulin, that this K is basically symbol for lysine. So you can see that K and P are reversed, and it become PK to KP. That is lysine and proline are reversed. So it become a rapid acting from regular insulin. So just they have changed lysine and proline, and it become more rapid. Similarly, they have added. They have changed this SPART molecule in lysine. It become SPART insulin. Similarly, with glutamate and lysine changes, they have made this in the third position and this 29th position, they have made glulysine. So basically, these rapid acting insulins are basically just one to two amino acid chains in the regular insulins. And for glargine, they have added two more arginine. So arginine is a basic amino acid, and they have also added one glycine in 21 position in HN. So by doing these changes, they have made insulin which is soluble in acidic pH and become insoluble in alkaline pH, and that is the property why glargine, when injected in the body, uh, it releases very slowly, and uh, that is the reason why glargine cannot be mixed with other insulin. So these two facts we should remember, that glargine cannot be mixed with any other insulin, and that pH dependent action is basically for only one insulin, that is glargine. And the detamer insulin, we have added one fatty acid because it was found that uh, you must have heard that we can add pegylate. We can pegylate the molecules to make them longer. For example, pegylated interferon. Similarly, in insulin also, if you add fatty acids, it will have a longer duration of action. So in Datamir, we have added uh, like we have removed the last amino acid, and with the lysine, 29th lysine, we added one fatty acid molecule, and it become Datamir. So if you see the release pattern, like when rapid acting insulins, like insulin normally form hexamers, so the more complex hexamers are formed, more slowly it will release. So if you see longer acting insulin, they will form multi hexamers, and normal insulin will form hexamers. But those who are uh, in the, for example, rapid acting, they will form small hexamers, or they will form monomer or dimers. So they will release faster. Similarly, if we add regular insulin into the saline, when we infuse, so in the saline, the all insulin will act as a regular insulin, and they will be not. They are given basically IV route, so their action will be between 15 to 30 minutes, not like 2 hours and 4 to 6 hours. So any insulin in saline will have very rapid onset, and duration of action will be in like 30 minutes and 15 minutes. So I already discussed like how glycine is formed. Glycine basically we have added uh, two molecules of arginine in 31 and 32 position, and that we can see here. And we have added one more molecule uh, in the 21 position, that is now glycine. Similarly, these are the changes we have done in aspartate. We have added aspartic acid in instead of this proline thing. Then for Lespro, we have just exchanged these things, and for glucosylysine, lysine, and uh, uh, glutamate, these are the amino acids which were changed. And this is the molecule of uh, like we have added myristic acid, that is the detamir, and you must be knowing that jaifal. Jaifal is very like Indian garam masala which is used uh, commonly in our kitchens. That has this myristic acid, and that was added to this insulin molecule, and it become tetamir, and that is one of the longer acting insulin. So uh, if we ask how many like we just solve few questions, so that I see that uh, how many of you are understanding. uh, so how many amino acids are present on the B chain of insulin? So we'll take the questions at the end, because it is screen sharing is stopping. So I'll just okay. You can see the slides, right? Okay. So wait a minute. See. Okay. So 30 amino acids, most of you are answering. That is right answer. Short-acting insulin analog are more readily absorbed compared to natural insulin. Or false? You can come and answer this. Short-acting insulins analogs. Analogs are basically stro as part glycine. They are more rapid absorbed compared to that is regular insulin or not. Yes or no? You can comment and answer. So I'll just create one true. Okay. Yes, true for all. Please do this. So like all of you are right answer for this. Now coming to the next question, which insulin analog have removed threonine? B13. We have added something. So I told that one insulin we have moved last acid from beach. I have added one fatty acid. And fatty acid that is apple. So you have to understand that I am taking A, B, C. So I'm taking a poll now. So here we are adding one fatty chain. What fatty chain is doing, making it longer acting. So there are two insulin like that. We have added fatty acids. One I told datamir, and one I told didn't tell is diglute. There we have added one fatty acid. So in this one we have removed the right answer is datamir. That is option number C. I think many of you are not got those correct. That you revise that structure. You see this here. I have removed last 30 molecule and we added this in the lysine. We have removed the amino acid and added myristic, the structure of vitamin. So next, which insulin analog result amino acid modification is more soluble at acidic pH and less soluble at physiological pH. So this is very easy, I think. So again, I am conducting a poll. So people are getting confused with SPART. There are mixed results. Most of you have answered argin, that is the correct answer. The insulin, which is pH interaction is really your insulin. So that it's clear that you have to remember that glargine is the right answer. You know. So please remember this, and it is very important MCQ questions commonly asked. And then, which insulin analog has high affinity for serum albumin? Which this I have not discussed, but you have think if you know biochemistry. But even if you don't know, please think and guess like will be the right answer. Like which is more affinity for albumin? So which are the molecules with more affinity? So I am conducting polls. So bind to albumin. Basically, you need fatty acid molecules. So degludac and detamine, they bind to albumin with high affinity. So that is the right answer for the right answer will be there. So coming up, insulin regime. How insulin is so many of you in third year and fourth years and those who are intern and medicine and done MBBS, they will be more familiar. But, try to understand this concept. Like for we need to give two types of insulin in the body: basal insulin, NPH, or lantus, that is in, or detin, or degludac. So in first giving long acting, so it can be any longer acting which covers like throughout the day, and we are giving three analog insulin. It is like once a day, and with meal every we are giving uh, log insulin. So this is the most common and like people who are affordable allergy. And this another insulin where we don't have glargine, we can add NPH times per day, and we can add regular this analog insulin that is called. So this is basal bolus regime. This is split in the split mix. We have NPH and uh, we can add morning, evening regular insulin, and even we can add also regular insulin if needed. So most of the time here also we need regular insulin, though it is not seen in this picture. But sometime in the fixed combination, you must have said people who are taking 30 by 17, which has 30% regular insulin and 70% insulin. They are taken two times. So for some people it is good, but it is not good for most people. And here you see basically infusion pump insulin, that is in pump with a basic rate, and it can be increased in morning hours, and it can decrease in the night times, and it gives bolus we eat without we don't do inject time like every time. So how the dose of insulin is calculated? Like basically uh, it's mainly depend on many factors. Like what are those factors? Body weight. So if person is whatever body weight, requirement is around 60%, for example, 50 to 60%. That is the minimum requirement. And for one diabetes requirement between 0.5 to 1 unit per kg. For type 2 diabetes, initial requirements like points. So if a person comes to me of, for example, 100 kg, I will start 60 of total daily dose, 60%. Again, this is for a normal healthy person. But if someone is very old, for example, somebody is 80-year-old, 70-year-old, we will not start with 60%. We will be like 50 or 40%. So the more is the age, 90, you can do 30%. So This is one of the factors to consider. And there are many diseases like coronary disease, kidney disease, liver disease. Those are factors. You will not start 60%. You will start with like 30%, 20%. Somebody who's not eating, all these factors to compare. But somebody who is preserved and diabetic, in that case, we need start 6% or 50% of total. So somebody 3 kg means we can 30 units. This is total dose. Now 50% of it will be basal dose and 50% will be bolus dose. So out of 60, NPH or land will be 30 unit and regular or NF will be again 30. So now after that we need to also calculate like how these are divided. We give 2/3 of the insulin in the morning hours and 1/3 in the evening hours. So morning and afternoon we have to give 2/3 of the insulin total. So if it is total dose or 30 unit total dose, 20 unit will be in morning hours and 10 will be in night hours. And again, we have to do 50-50 between PH and regular. So do that exercise in coming slides. The other factor is insulin carbohydrate ratio. So like if somebody is eating 10 gram more carbohydrate, how much insulin you need to take? So that is, the formula is 500. That is called of 500. That is 5 divided by total dose. So 500, like this person, total daily dose, suppose 30 units. So 500 by 30 will be roughly 15, 16 के आसपास है. So 15 grams will be requiring 1 unit of insulin. So that of 5. Somebody is requiring, for example, 50 units of total daily. 550 will be 10 grams. So one will reduce 10 gram of extra carbohydrate. So this is for like somebody who take 2 chapatis. Tells that I take 10 gram chapati. So how much you need to give? You will give more 1 unit. And how is coming by 500 by total dose. So somebody whose daily dose for example, total dose is just 10 units. Then you will divide by 50 gram carbohydrate can be managed as 1 unit. Then there is another factor called correction factor. That is called of 1800 for NOAC and Epidura and 1500 for regular insulin. And here we do 100 by total dose. Somebody taking regular insulin 50 units per day, divide 1550, it is 30 milligram. So if you hyperglycemia, suppose you have done fast burst and now it is 180, and you are taking, for example, less than 1/3, so you have to reduce 180 minus 30 is coming around, or 120 is coming around C. So you need to give unit because 1 unit they reduce from 1 to 150, another 1 unit reduce 180 to 120. So this is for any patient who is on insulin and is not well controlled. So we will do exercises in next again, so that these will be like, remember these tools and read about them at home. And, then we'll practice questions related to these tools in coming. The 300 is for correction factor and 5 for carbohydrate factor. Now, the questions I already discussed how these rules are. This is my magic number for split mix regime. How magic number we get? If you are thinking that somebody is, for example, total dose is for example 50. So if you divide by 6, so whatever total daily dose you're thinking, how total daily dose you are making 50 or 60% of body. Somebody is 60 kg. You assume that daily dose is 30. So because it is 50 of that number. So 30 by 6 will be 5. So magic number will be 5. And here in this example, 50 by 6 if you do, magic number will be really 8 point something. So we can notice 8. So we have, if we are giving NH and regular regime, we can use double of that as NPH. If you have 8 as magic number, so morning NPH will be 60 and morning insulin will be 8. Afternoon insulin will be, regular insulin will be again 8. And night NPH will be 8, night regular will be 8. So these are rough estimates. Normally give less towards the late hours, and we give more towards morning and afternoon. And again, we have to vary depending on how much meal the person takes. So these all were basically about insulin types and insulin how to. We will solve in the next question related to this. One of the very important topic in our areas and for PG is diabetic ketoacidosis. So this is one topic I'll discuss. Now I'm doing patient will present basically nausea, vomiting, diarrhea, polydips, abdominal pain, shortness, and always a precipitating factor. So these are these infections, insulin, inadequate insulin. There are infections, some myocardial, coronary, or peripheral. Then there are cocaine, pregnancy. These things are precipitating factors. And patient will have hydration, tachypnea, small preparation, tenderness, lethargy. So when we see this patient, we need to test them, and basically that is based on our glucose numbers, then arterial gas, and ketones, blood ketones. There are conditions which diabetes and MC, that is DK and HSS is hyperglycemic, hyperosmolar state, and both have high glycemia, but glucose levels are much high in HHS, and it has less ketosis. So if you see once they are mildly positive or negative in case of HHS, but it will see high in case of DK. Similarly, natriuria is much common in DK. So all these are CQ questions. Like potassium will be normal or high in case of K. So because this DK actually is potassium actually causes shift of potassium from cellular to intracellular. So when it is deficient, extracellular will go out. Similarly, magnesium will be magnesium chloride and phosphate. They are very normal most of the time. Osmolarity very high. So that in case of hypermolar coma, and kids are already told bicarb will be less than 15 or 18 kPa. pH will be lower in DK, 6.8, 7.3, and CO2 will be 20 to 30, and anion gap, sodium minus chloride carbonate of DK. This is very important question in MBA as well as in MCQs. This chart difference you need to remember very quickly. Then how to DK? Basically, there are 2 points. It's has, and you must remember these 12 points. First is to perform the diagnosis. So the DK needs 3 things. You need to have high glucose. Normally it will be more than 250. But you can have DK with normal glucose with a drug, which is very common used now for diabetes. It's called SGLT2 inhibitors. We will discuss these when we discuss which is, but you can have glycemic DK also. So, but normally, say DK when glucose levels are more than 50. Then positive ketones. But ketones level should be 1 point more than 0.6 moles to say it is the DK. Then there should be metabolic acidosis like pH less than 1.3 or 0.25 to say DK. So these triads should be. Then, if it is the case, we should meet, especially in ICU, the severe acidosis there. And first thing to do is send the sample of electrolytes, including bicarb, phosphate, and our ABG to know the renal functions and monitor urine input. And before giving any, we need to give fluids, especially for adults. See, treatment of child child decay is little different because they have more cerebral edema associated decays that I will discuss sometime separately. But for patients, fluid is the key of decay. So always start treatment of fluids. That is 2 liter of 0.9 saline 1 to 3 hours. So 10 to 20 ml per kg per hour. And after that, because you are giving so much sodium, you need to do 0.45% saline because after 2 days, what happens, they will have hyperchloremia that will cause normal anionic acidosis. So that we need to think. Again, because glucose level will cut faster compared to ketone level. So as soon as your glucose below 250, start D's, 5% glucose plus 0.45% saline solution when our glucose is less than 50, and we keep glucose level between 1 to 250, and we continue give insulin for as long as ketones are present in the blood. And after starting the fluid and hydration, we give bolus of 0.1 unit per kg. So high insulin should not be given because cause any harms. So the treatment is just 0.1 unit per kg. 60 kg you give 6 unit of IV insulin, and after that start infusion of the amount of insulin. So for 60 6 unit of insulin per hour continuous infusion. And need to check the sugar response, and more important is like if potassium levels are, because it is pseudo elevated in diabetes. So if it is less than 0.2, we need to replace it. So if it is in 3.3, we cannot give insulin. We have to correct potassium first, and then give the insulin. So these are the questions that less than 3.3 dose insulin, less than 5.2 you have to replace. But if it is more than 5.2 potassium, you need to replace. Then understand, try to understand what are the precipitate cause and treat that. So we have to do culture, chest raise, ECG, all things we need to do. And every 1 to 2 hours, continue to monitor that electrolytes basically, and monitor BP, perspiration, fluid intake, output. These are the 8 major points. And the last is potassium replacement that we told that around millicurie per hour we have to replace, and was already told. Then carbon phosphate normally we don't replace because when we give fluids, the carbonate levels slowly towards normal. This is the condition of phosphate. But if after treating, giving insulin, if very high and is something like 6.9 or bigger, then only if bicarb. So bicarbonate is generally not, it is only in very severe acidosis which is not responding. And phosphate should be replaced when it continuously or even after starting this treatment. You can give oral or IV phosphate depending on the phosphate levels. When we correct the glucose level and ketones are cleared, we need to overlap. So this is very important. Don't stop insulin and start something, because it will take a few hours for act. So overlap for 2 to 4 hours so that there should not be any rebound of hyperthemia. So the important point of managing TK. And this is the slide. Many people ask the phenomenon, Somogyi and Dawn phenomenon. This is very simple. Basically, Dawn phenomena, what it is due to deep diurnal variation. What is the variation of the hormone? In the morning, you have a lot of cortisol, adrenaline, and all those hormones. So, what happens? They hyperglycemia. And Somogyi phenomena, what is happening? It is secondary to high insulin, like you have taken more insulin in the night, so you have so much insulin in the body, and that is causing hypoglycemia. So you have hypoglycemia in the uh, if you have hypoglycemia in the morning, for example, you don't know like what is cause. Whether you had time hypoglycemia due to insulin, and secondary hyperglycemia in the morning. That is called because it is secondary, so it is Somogyi phenomenon. And dawn will be hyperglycemia because morning epinephrine and cortisol, all body hormones increase and called hyperglycemia. So in insulin, you need to give more insulin. You need to increase the dose of nighttime NPH enters. In case Somogyi, because insulin is causing hypoglycemia at night, we need to decrease the insulin. So that is the concept of Somogyi. So that's all in this talk. If you have anything, please ask. I think my voice was breaking. Okay, you can ask your questions. Hello, team Medwhiz.
You are now unmuted.
Yes, sir.
There's some voice issue. I didn't know.
Yeah, so that was because of the webcam. Now it is fine. Now it is going good, sir.
Okay. So what part? I think if it is not clear, I can just rediscuss that. What part of the discussion was not clear? If you can mention that, I can discuss that. Students, please ask like something which if you're not understood, we can rediscuss that. Not an issue. We have I think 10 minutes more. Okay, insulin carbohydrate ratio. Somebody, I think Diksha is asking. Okay, so for example, a patient coming to me, he is a normal patient, no other disease, only diabetes, and well preserved. Of like for example, 50-year-old patient of 60 kgs. So initial insulin, how much I have to give? So that is around 50 to 60% of body weight. So if somebody is 60 kg, I will give 30 kgs, that 50% of his body weight. So how 30 kg will be divided? So I told one magic rule, that is whatever you are calculating that number, divide by 6. So 30 divided by 6 will be 5. 5 will be your magic number. So morning NPH will be double of that. So 10 will be morning NPH. Then regular will be 5. Afternoon regular will be 5. And night regular and NPH will be 5, 5. So 10, 5, 5, 5, 5. This is NPH and regular regime with that. Now carbohydrate ratio. Suppose somebody is in good control with this insulin regime. So he asked like if I take for example 2 more chapatis. So that is around in nutrition class we'll discuss sometime that how to calculate carbohydrate of each nutrients. But suppose that chapati contain 20 gram of carbohydrate. So you need to know how much insulin we have to increase to cover that extra 20 gram of carbohydrate. So that number can be answered by rule of 500. So you divide like 500 by total daily dose. So what is the total daily dose? That is 30 for this patient. So 500 by 30. So that is roughly around I think 17. So around 17. So 1 unit will cover 17 grams. So this person is taking 20 grams. So roughly equal. So we need to increase his regular insulin by 1 unit. So he was taking 5 units of regular insulin in the afternoon, and that time he is taking more, 2 more chapatis. Now we will give 6 units, 1 additional unit for this extra carbohydrate. Suppose in afternoon he did his sugar check, and pre-lunch sugar was 180. So we were targeting something around 120, 130. So now it is more by how much? Almost 60. So we need to understand how much additional insulin we should give, because his sugar is 180 right now. So normally this is good. Like 5 we have calculated when his sugars are around 130, 120. But now it is more. So we need to correct this. So that correction dose can be calculated by rule of 1500 and 1800. So for regular insulin, we can divide by 1500 by total daily dose. So here total daily dose is 30. So 1 unit will cover 1500 by 30, that is 50. So 1 unit will reduce glucose by 50 units, 50 milligrams. So at 180, if we give 1 additional unit, it will reduce to 180 to 1. It will reduce to 130. So I think this is we have asked. But how do you decide those? This is basically based on weight, and then again we have to factor age, multiple comorbidities and other things. So that is very important. Any other questions? Any other question? (50-50) regular and NPH क्या है? Mixtard is still used in the treatment. Mixtard is basically a fixed form of insulin. And basically it is if you 1 second. Basically 30-70 traditionally we were using, and there are other form of mixed insulin also. 50-50 has 50% of regular insulin and 50% of NPH insulin. Mixtard traditionally had 30-70, but now it is also having 50-50 insulin. So those people, like when we take NPH and regular separately, we have to mix them. How to mix them, we will discuss in patient education class of insulin. But we can mix 2 types of insulin, different ratios. Good thing with the fixed insulin is that number of pricks are decreased. Like for example, if you are taking in the morning, you need 2 prick if you are taking them from separate bottles of NPH and regular. But these pre-mixed insulin have both are in 1 bottle. So you just need to take one. It will have 50% of regular insulin, 50% of NPH in case of 50-50, and in case of 30-70, 70% of the NPH and 30% of regular. Same combination also comes with analog insulin. So they are still very good options, especially for older patients, CKD patients, those who are having very fixed lifestyle. So for these insulin, your diet and other things should be very regulated. You cannot be very hodgepodge, because basal bolus regime, where we are giving separately, you have more freedom. Suppose if you are not eating lunch, you can skip the insulin. If you are eating half of the lunch, you can take half of the regular insulin. But with these combination, we cannot modify that, because we have 2 types of insulin in the same combination. I hope your You got your answer. Any other question? Harsh, I think I answered you. Any other questions? Please ask. Please feel free. Yeah. No need of being very formal. You can ask your doubts and because you should not go with doubts in mind. Anything you need to you want to ask,
You are
please
now
ask.
muted.
That will be make this lecture very useful. So anything, if small doubts also, if you are coming to your mind, please discuss. We can close this session in 5 minutes after that. So please come forward with any questions if you are feeling related to insulin or any other thing. So somebody also asked, what is NPH? So that protamine, if you remember medicine very clearly, protamine is antidote of heparin. If somebody has got high heparin injection, high dose, and that is leading to bleeding, protamine is used to reverse that. So it is a very strong molecule which binds. So I told that if hexamers are more, the duration of action will be longer. So what protamine does, zinc and protamine, it binds insulin and form more and more hexamers. So that is leading to more slow release of insulin. So that is the molecule protamine in NPH. Then, sir, what are the intervention relating to the management of diabetes? I think question must be something else. Please ask if somebody asked this question. I'm not clear what you're asking. I think this question is not clear. If somebody is here, you can ask that. Okay, so if there are no more questions, we can stop this session. And next session, we will cover OHAs and we'll take a separate lecture for diabetes education that will cover how to take insulin, how to mix them, and the insulins, and how to select the sites of insulins, like how to inject, which site is the site, and how to do rotation, how to keep insulin in storage, how to transport, and all those aspects we will discuss separately in one of the lectures. And we will cover OHAs and management of diabetes complication in one separate lectures. So I think that's all. Thank you, everyone. I think Team Medwhiz, we can end this session. Somebody is...
You are now unmuted.
Sure, sir, sure.
Okay, bye-bye.
Thank you, sir.